systematic review on the value of quantitative image analysis in breast cancer diagnosis. My supervisors are Dr. Andrew, Professor Mark, Professor Ahmed, and Dr. Claire. This work was conducted as part of my PhD program at UCC, funded by Government of Tanzania. I have no any conflict of interest. This is the outline of my presentation today. I'll be looking on the background and the aim, methods used, results, conclusion, and what is the clinical implication of the results. Breast cancer is the most prevalent cancer in women globally. Image play a key role in its diagnosis. The key diagnostic tools are mammography and ultrasound. This conventional image currently depend on the report from radiologists who use qualitative assessment of the image to give their reports. But image have extent of covert information that can be extracted quantitatively and can provide the phenotypic and genotypic information about the lesion. So this review was aimed at evaluating and comparing the quantitative image analysis and qualitative image analysis on its diagnostic accuracy. This was the systematic review and meta-analysis. The review was registered in Prospero with registration number shown. We searched on 6 databases and end up to include 6 studies, which both had comparing the qualitative analysis to quantitative analysis in identifying malignant and benign lesion. So 4 of the study were mammography and 2 were ultrasound. This is a plasma flow chart that summarizes the review process and how we ended up with the 6 studies. Pooled results show that qualitative analysis and quantitative analysis are comparable, but however, the quantitative analysis has more is more in discriminating the benign lesion with 12% higher specificity. This difference was statistically significant, and their diagnostic performance was numerically high to quantitative analysis, but the difference was not statistically significant. These are 2 forest plots showing the individual results for the 3 included studies and the pooled results for their sensitivity and specificity in both qualitative and quantitative analysis. So, in conclusion, incorporating quantitative image analysis into qualitative assessment had the potential to reduce false positive results and lower biopsy rates in breast imaging diagnosis. What does this mean clinically? It means that we will have fewer false positives and fewer unnecessary biopsies. This will reduce patient anxiety from the biopsy procedure itself and the time to wait for the results. Also, we'll have better resource utilization in our societies. These are my references. I hope today's presentation have provided an insight on the value of quantitative image analysis in breast cancer diagnosis, and thank you for listening.
Thank you so much, Sahura. Okay, so if people do have questions as we go, please put them into the chat and we can answer some questions later on. Thank you, Sahura. So the next presentation is from Teresa O'Donovan, and Teresa is from the discipline of medical imaging and radiation therapy. And Teresa, do you want to share your slides there?
Sure.
Great.
Can everyone see those?
Yep, perfect. Thanks, Teresa.
Beautiful. So hello everyone, thank you for the invitation to speak today. I am just going to give you an overview on my PhD project, which is around weight stigma and bias in medical radiation science. And this is funded by UCC. So I suppose if we think about the literature, there's lots of terms to describe attitudes towards individuals based on weight, including anti-fat attitudes, weight bias, weight prejudice, and fat phobia. So we've taken the term weight bias, and it's well established in healthcare literature in various allied health professions, but there isn't very much literature around it in medical radiation science, so including radiography, radiation therapy, ultrasound, MR, etc. So our plan was to first of all look at the evidence, so to conduct a systematic review around tools that are used to assess bias. And then the plan was to conduct a quantitative study, so looking at a survey and designing a survey to assess bias within the professional population. And then moving on to the third work package and trying to delve a little bit deeper by talking to both people who had lived experience of medical radiation science and also talking to professionals. So our first port of call was to design a protocol for a systematic review, and this has been published in PLOS ONE. So the aim of our review was to basically look at tools that are used to assess weight bias in both students and health professionals in medical radiation science within both education, training, and clinical practice contexts. So we have completed this review. There were 6 articles that were published within the last 10 years, and we found that there was a huge variety in the assessment tools that were used, and they demonstrated low to moderate levels of bias depending on the type of tool that was used. However, all of these studies had very small numbers. There were no control groups, and also there was very few radiation therapists within the cohorts studied. So I suppose this has led us to looking at that work package 2, where we wanted to conduct an international study, utilize hopefully validated tools, and try and get as many professionals involved. So we designed a survey within Qualtrics to quantitatively assess weight bias. We conducted this internationally. We had a really, really good response, and we had 663 people who responded and who completed the multiple tools that were within the survey. And we found low to moderate levels of bias. We did find that there was a gender difference where males demonstrated higher levels of bias. And we also found differences within BMI. So respondents who had a higher BMI demonstrated lower weight bias. So this paper has been submitted to JMIRS this month. So again, I suppose what we found is that we needed really to gain a deeper insight into the professionals' attitudes. We wanted to gain a deeper understanding of the impact of bias on those with a lived experience to allow us to inform potential interventions. So the next step is our qualitative research. We have received SHREC approval. The plan is to conduct 2 different arms. So we want to conduct semi-structured interviews with professionals, and we also want to conduct semi-structured interviews with patients and service users. So the next step within that plan is to engage a PPI panel to gain insight into, I suppose, how to advertise this to people, but also what questions we should be asking both professionals and those with a lived experience. And we've also had advice from our external annual progress review panel in that we should engage additional supervision or supervisors with qualitative research background. So that is the next part of the plan. And these are my references. So thank you very much.
Thanks so much, Teresa. It's fantastic. Okay, and same thing again, if there are any questions, please pop them in the chat. So our next presenter is Erica Bennett, and Erica is a PhD student in cancer research at UCC, and also a radiation therapist. Erica, do you want to share your screen?
I will, thanks very much.
Super. Yep,
All
you can
okay?
see it. Thank
Great,
you.
thanks very much. Thanks for the invitation and the introduction, Aisling. I'm the Oncology Clinical Research and Development Lead at the Radiotherapy Department in the Bonds. I'm in my first year of my PhD, which is titled Evaluating Health-Related Quality of Life in Patients Receiving Prostate Stereotactic Ablative Body Radiotherapy. My disclosures are that my funding and I have protected time provided from my employers. So just as a bit of background, then stereotactic ablative radiation therapy, or SABR, is an advanced radiotherapy technique which utilizes higher radiation doses per fraction or per session than the conventional radiotherapy, and it offers higher precision because we target smaller volumes. In localized prostate cancer, which is my study population, randomized control trials have shown excellent overall survival of around 84%, low rates of biochemical or clinical relapse with SABR of between 4 and 8%, depending on the specific study. And SABR has comparable outcomes with other treatments such as surgery. It does, however, cause some toxicity. There's bladder, bowel, and sexual dysfunction side effects with SABR and radiotherapy, and this has an impact on a patient's health-related quality of life. But the magnitude of that is, I suppose, uncertain at the moment, and research shows that clinicians and healthcare professionals often underestimate the impact of health-related quality of life. And health-related quality of life is measured through patient-reported outcome measures, so quality of life questionnaires. And currently, there are 17 different PROMs used in localized prostate cancer, which I have listed there. This causes a lack of standardization across studies, and it makes the results between studies quite difficult to compare because there's different varieties and combinations of quality of life data. EPIC 26 is the most commonly used tool, and it incorporates 4 domains: urinary, bowel, sexual function, and hormone impact. And it's a prostate cancer specific tool. So potentially it is the most appropriate tool to capture health-related quality of life for prostate SABR patients, but we just don't know that yet because it hasn't been specifically validated in this population. So this is my research question, is how does SABR affect the health-related quality of life of patients with prostate cancer, and is EPIC 26 an appropriate tool to measure this? My aims and objectives are to evaluate how SABR affects the health-related quality of life in this non-metastatic prostate cancer population, and to prospectively validate EPIC 26. So I want to look at the longitudinal changes in the health-related quality of life data, do a psychometric evaluation of the EPIC 26 quality of life questionnaire, and ultimately make recommendations on the future use of PROMs to measure quality of life. So I'm doing this through a mixed method approach. So the first thing I'm going to do is a qualitative study to get some insights from the patients on their perceptions in completing PROMs, because quite often in studies there's a lot of missing data, and I want to ascertain the views and barriers for patients completing PROMs having had prostate SABR, and also to identify if patients think PROMs accurately represent their health-related quality of life. And I'm going to do that with focus groups. And then the second part of my PhD is to evaluate some quantitative data to actually statistically look at the health-related quality of life of patients, and review the PROMs from prospective and also retrospective SABA studies. At the moment, as I mentioned, I'm just in year 1 and I'm doing this part-time. So this is just my, I suppose, outline of the time. I've just spent the last kind of 6-8 months just doing some foundational modules and orientating myself into the PhD world, defining the research question. And then the next year, then I'm going to do a systematic review and really, I suppose, write my study protocols, ethics, and get some funding for the next steps, which will be conducting my actual research. So I'm going to start, like I said, with the qualitative focus groups, and then really dive, I suppose, into the data with some statistical analysis of existing studies and also some prospective studies. And then at the end, I will hopefully bring all of that together and have some recommendations for future practice. So my final thoughts, and just to leave you with this, that the needs of people with prostate cancer are unmet. We cannot improve health-related quality of life outcomes if they're not appropriately captured or understood. And this is basically which underpins my PhD work. And I would like to say thank you to my supervisors and my mentors, and my references are there. Thank you.
Thanks so much, Erica. That's great. Thank you. Okay, so we'll move on to our fourth speaker, who is Poonam Jaswal, who's from the School of Nursing and Midwifery. Poonam, do you want to try and share your slides? Okay, something's coming up there. Yep, we can see them now. Yeah. And can we hear you okay?
Am I loud enough?
No, you need to speak up a little bit more, I think, Poonam.
Okay.
Thank
Can you
you.
hear me now?
Yeah, you're just quite faint. So, yeah.
Perhaps turn off your camera as well, Poonam, if you don't mind. It might just preserve the Wi-Fi if you're connecting in from somewhere where the Wi-Fi is dropping a bit. It might help. Sorry, Ashley.
No, you're fine, Josephine. Yeah.
Can you still see my screen?
Yeah, we can, but it's gone out of presentation mode. So, yeah, now it's back again. Okay, go ahead.
Great. Good afternoon, everyone, and thank you, Aisling. My name is Poonam Jaswal. I'm third-year PhD student, and today I'll be sharing the findings of my study that focuses on integrated and shared care as service delivery models for cancer and other chronic conditions. Just to highlight, my PhD study is being funded by the School of Nursing and Midwifery. So just to provide a little bit of background to my study, integrated care and shared care are two concepts that are used interchangeably in policy and practice. And currently, there is no agreed upon definition for both of these concepts, which does create confusion as to how they are understood and applied. The context of 4 chronic conditions, that is cancer, cardiovascular diseases, chronic respiratory diseases, and diabetes mellitus, was considered for 2 key reasons. Firstly, World Health Organization recognizes these 4 conditions as major contributors to global mortality and morbidity. And secondly, examining all of these 4 conditions helped guide gaining deeper understanding of how these concepts are actually understood and applied across by different clinical disciplines. So the aim of my study was to examine the existing conceptual, theoretical, and operational understandings of integrated and shared care as service delivery models for cancer and other chronic conditions. And the methodology employed was 3-phase principle-based concept analysis by Smith and Morales, where the concepts were analyzed under 4 philosophical principles as well as their conceptual components. Moving to the next slide. So this slide illustrates that across the concept analysis, a total of 65 studies were included. And of these, 42 focused particularly on integrated care and 23 focused on shared care. It is worth noting that within integrated care, the majority of the literature was represented in the field of diabetes mellitus, while in shared care, the majority of the literature came from oncology setting. So just moving on to the final result, both the concepts hold common as well as distant domains between them. And both concepts, when they're applied as service models, the common domains that are relevant to both of them include the patient inclusion criteria, clear roles and responsibilities for care providers having training and education prior to the implementation of these concepts as models, evidence-based guidelines and protocols being used to structure and informing the implementation of these models, communication and information exchange between care providers as well as patients occurring through the use of appropriate technology and relevant care documents, and there being supplementary care support system in place for care providers to support clinical queries as well as concerns and patient reassessments in form of rapid patient clinics. Both the models were found to have and deliver rational as well as sustainable use of resources. What distinguished integrated care specifically were the domains such as well-defined exit criteria for the patients, multidisciplinary team, co-location of the services, and care providers playing particularly pivotal role in the form of either care facilitators or program coordinators or care coordinators. Shared care, in contrast, it focused particularly on the collaboration of specialists and primary care providers, and general practitioners play a significant role within shared care. In specific to cancer care, within integrated care, what really stood out in the finding was two factors such as the multidisciplinary team and the co-location of the services, which contributed to positive outcomes achievement. And that was in particular to notice in sense the teamwork, collaboration and coordination was further enhanced, which led to improved continuity of care, positive patient satisfaction and effective patient-centered delivery of care. So just to conclude, the findings highlight that the strength of healthcare is not in its individual services, but in the integrated care system that unites them around the service user. And critically, language matters. So how we define them and use them is very important so that they are understood and implemented and evaluated clearly and consistently in order to build credibility as well as effective delivery of service models. Thank you. If you have any questions, I'll be happy to take in later.
Thank you so much, Boona. Okay, so we'll move on to our fifth presenter, who is Katie Johnston, who's from the School of Food and Nutrition Sciences and Cancer Research at UCC. Katie, do you want to see if you can share?
Thank you very much. Ashton, can you see that okay?
Yep, it's up there. Thanks so much, Katie.
Perfect. Thank you. Thank you very much, Ashton, for the introduction. So I did my PhD with the School of Food and Nutritional Sciences, and I also worked alongside cancer research at UCC. So my supervisors were Dr. Samantha Cushion and Professor Aoife Ryan. And really what I want to do today is give you a bit of an overview of that research that we did. So really reimagining survivorship care. This PhD was funded in part by the Irish Cancer Society and Breakthrough Cancer Research, and the PhD was partly self-funded and received some funding from the School of Food and Nutritional Sciences. So today I'm hoping to kind of, in true dietetic fashion, serve you up a bit of a three-course meal. starting with the problem and finishing with some topics for conversation. So starting with the problem with dietitians, research that I conducted in the UK that looked at breast cancer survivorship really came out of patients saying it was like being pushed out to sea on a boat with no oars. What do they do now? And furthermore, we know that research in Ireland has suggested that breast cancer survivors are the most likely to desire dietetic support, but actually the least likely to receive it. And dietetic care needs after breast and gynecological cancer treatment are complex, particularly with the impact of treatment-induced menopause, be it through an adjuvant endocrine therapy or be it through something like a hysterectomy or pelvic radiation as well. And these needs aren't particularly met. Normally for dietetics in oncology, our focus is on that acute toxicity that malnutrition can bring and not really dealing with the after effects of cancer treatment. So what is the problem with dietitians? Well, currently there is one oncology dietitian for every 4,500 oncology patients in Ireland, and that does not include those that have completed treatment. So what is the solution? Well, what if high quality dietetic care is feasible, but we have just been looking through the wrong lens? What we learned was that digital symptom triggered dietetic care can work in women with breast and gynecologic cancers. We tested it in 200 women in Cork University Hospital and in University Hospital Galway, where we sent out participants a symptom survey every 2 months for a year. They completed that survey, and based on their responses, it trigger initiated a virtual call with myself or the nurse. What improved? Well, we found that weight gain concern reduced significantly in those that received the intervention in the randomized control trial, and that their body composition remained stable. We also have some suggestions to say that their quality of life, including fatigue, anxiety, and depression, also improved in those that received the intervention. But it also revealed very many gaps. Supplements were used to self-manage symptoms. We looked at this in over 250 women who were diagnosed with cancer and maybe subsequently was experiencing treatment-induced menopause. Concerningly, we found that 40% of these supplements had interactions with their adjuvant endocrine therapies that they were taking. They were rarely disclosed to their medical teams as well. We did some qualitative research and we found that there was really some practical and structural constraints in this communication, and also the perceived disinterest and skepticism from our medical professionals as well as our healthcare professionals too. And we also found that traditional tools failed to capture nutritional risk in this cohort. So where do we go to next? Well, we really need to redefine dietetic care. We need patient-designed tools, we need to embed dietitians into room care, and we need to develop clinical and patient education. So I'm really delighted to say that we tried to do some of this. We produced Menopause, Diet and Cancer, both a book and a webinar series that really for the first time dealt with the nutritional needs of this cohort of patients. It was shaped by the voices of 16 women who so candidly shared their experiences and hopes for how dietetic care should look following cancer treatment. And we had fantastic engagement with it on the island of Ireland. We hand delivered over 2,700 books free of charge throughout Ireland and Northern Ireland. We had over 7,000 online views and downloads of the books. We produced over 3.5 hours of educational content for both patients and healthcare professionals. And we have over 2,700 webinar views on the Irish Cancer Society's YouTube channel. And I'm delighted to say that we have produced 6,000 more copies through additional funding from Breakthrough Cancer Research. So what did we really learn and what do we need to bring forward? Well, what we learned was that there's fundamental gaps in these nutritional screening approaches. Conventional tools miss these survivorship-specific nutritional risks, and that includes weight gain, sarcopenic obesity, and symptom-driven dietary compromise. We know that dietary intake, symptom burden, and supplement use are all interconnected. They're not independent phenomena. So this really requires us to be flexible, have a symptom-responsive approach to nutrition support that really does challenge conventional interpretation of dietary quality. We know that the LISA model demonstrates the value of integrated team-based care with dietitians really at the centre coordinating that survivorship support. And we know that evidence-informed interventions and resources that are co-designed with patients and clinicians really do improve this acceptability, the relevance, and the real-world uptake. And finally, these findings really do inform survivorship pathways. They guide dietetic practice and they support coordinated multidisciplinary care across the cancer journey. So I would like to thank everyone that helped with this. It really does take a village to conduct this research, particularly to the LISA team and all to those at Cancer Research at UCC. So thank you very much.
Thank you so much, Katie. That's excellent. Okay. So we will move to our final presenter of this lunchtime series, Stephanie Lawrence, who's from the School of Nursing and Midwifery. Stephanie, can you share your slides there? Perfect. Thank you.
Great. Thanks for the introduction and thanks for the invitation. My title is Cancer Awareness Amongst Adolescents in Irish Schools. It's a cross-sectional study. I've just finished my final year in my PhD, and I'd like to thank my supervisors, in particular here today, Professor Josephine Hegarty and my other team of supervisors. This was a multi-method study, consists of a number of phases. Today I'm going to present on phase 3, which was the quantitative study. Phase 1 would have been a published systematic review on barriers experienced by adolescents when accessing GP services, and the second phase was a published systematic review looking at cancer awareness amongst adolescents. Again, this was partly funded by the Marie Keating Foundation, so I'd like to very much thank them for that opportunity as well. So sorry there. Okay. So the aim of the study really was to measure adolescents' cancer awareness. We used a cancer awareness measurement tool. This tool was obtained from Cancer Research UK. It was a tool that had been used for a number of years with the adult population. So in 2013, this tool had been amended to be used amongst adolescents. So we sought some permission from Professor Coyle in the United Kingdom. We gave us permission to actually use this tool. So the design was a cross-sectional survey design, and we obtained then ethical approval through UCC back a number of years ago. So we were lucky to have succeeded in our ethical approval. So our recruitment stage involved quite a lot of key areas to consider, considering that we were collecting data from adolescents under the age of 18 years. So from a point of view of recruitment, the schools, there's a list of schools available. We decided to focus on the Munster area as a geographical area. So we had a list of schools from the Department of Education website. We therefore then sent an email to the principals in the school, focused mainly on the transition year coordinator, or particularly interested in adolescents aged 15 to 18 years. So on reply, 9 secondary schools expressed interest in taking part in the actual study. So in order to take part of the study, it was a pre-post survey. We had an intervention on cancer awareness from the Marie Keating Foundation. It's an intervention called Your Health, Your Choice, and it's mostly about creating awareness around cancer signs and symptoms and risk factors. So it involved a lengthy process of consent and assent. So the information packs were sent to the parents, sent to the school, sent out to the parents. Parental consent was required for students to take part. And then, as I said, our students or adolescents had to provide assent as well. So data collection occurred in person in the schools, and the schools organised a room for the collection of data and the presentation to take place. And that was for a duration of about 2 hours, which included the intervention and the pre and post. But today we're just going to focus on the pre-results only. So in our final sample, we had 477 surveys collected. We excluded 3 due to missing data. So our final sample was 474 adolescents, again, as we said, aged between 15 and 18 years. So the data collection tool, as I mentioned, the cancer awareness measurement tool, is a very valid, reliable tool. It collected the socio-demographic information from the students. This included some closed questions. The second part of the survey was about recall. So adolescents were asked to use free text responses, open-ended, on their understanding of what a cancer sign or what a cancer symptom might be. And then on the third part, there was a list of potential cancer signs and symptoms that we asked the adolescents, you know, do they agree that this might be a cancer sign or symptom? There's a section then on barriers to help seeking. Again, there were closed questions. Cancer risk factors, again, was more to do with the recall and recognition. And then we asked adolescents if they knew about any cancer screening awareness programs specific to Ireland as well. So just focusing on the findings, a lot of data here, but it's interesting to see from an overall point of view, lump and swelling was certainly recalled by a number of adolescents. So accumulation of over 71% recognised lump and swelling and documented that, whereas there was the least number that looked at like change in bowel or bladder habits, for instance. From the recognition point of view, again, you're looking at 94.1% of adolescents recognised lump and swelling. And again, a sore that doesn't heal was the least most recognised cancer sign and symptom. Looking at cancer risk factors, again, quite a lot of adolescents identified smoking as a cancer risk factor, 78.3%. And this is quite high amongst people who knew someone with cancer. And on recognition, again, you can see smoking any cigarettes, 93.7%, although eating less than 5 portions of fruit and vegetables was least recognised. Barriers to help seeking, the most barrier to help seeking was, from an emotional point of view, was worrying about what the doctor might find, looking at 68.1%. From a screening point of view, in Ireland, breast screening was recognised by adolescents at 70%. However, many were unaware of the bowel screening programme, with just 35%. So just looking at the findings overall, we identified there are significant gaps in adolescents' knowledge of cancer signs and symptoms, risk factors, and in particular, the importance of early detection. We also identified again that there are gender differences where females generally demonstrate greater knowledge. And again, knowing someone with cancer positive influences adolescents' awareness. So from the implications point of view, the findings highlighted that there really is a need for targeted cancer education and awareness interventions amongst adolescents. We need to address the emotional barriers that they do experience when they do seek help. We certainly need to promote a lot more healthy lifestyle behaviours like eating more fruit and vegetables. Phase 4 of the study is a qualitative study, and that is in preparation for publication, where we asked adolescents what they would like to see in an intervention. And again, I suppose it's really very much focused on experience-based co-design, that adolescents are very much involved in the design of that cancer awareness programme. So I'd like to thank you all for listening here today.
Thank you, Stephanie. That was a fantastic overview of whistle-stop tour, really, of your PhD. And I suppose today we've been very lucky to hear from a variety of presenters at different stages of their PhD, covering different topic areas, and a spectrum of experiences shared with us. And I know from Emily, this is the final of our series, and we're really at this stage very thankful to all participants, all chairs, all those who attended, and to Emily herself for all the organisation of the series. And the series will be back again in September for the 26-27 series. But we're here today and we're ready to answer questions and ask questions. So if you have any question for our fantastic PhD presenters, if the PhD presenters could turn on their cameras, we'd be delighted. And we might take a Q&A session at this stage. And thank you to our presenters. You were amazing. You kept to time extremely well, which was really, really helpful in terms of Aisling's job and my job, in terms of keeping this to within the hour. So we're really appreciative of that. Are there any questions? If you can't put up your hand, please jump in. I don't see anything in the chat. I have 1 or 2 questions myself that I can ask, but if there's anybody who wants to jump ahead of me, please do. No? Okay. This is a pretty hopefully okay question to ask you all. And it's a question that I know Poonam will laugh, because I ask this question all the time. And I'm asking you to imagine that you're in the lift with the Minister for Health, and you have from the first floor to the sixth floor, it's 30 seconds, one sentence to tell the Minister for Health the key message, key finding from your research to date. One sentence only. What would you say? And it's a difficult one because people tend to go on for about 5 or 6 or 7 sentences, and you can imagine that it stops. So you introduce yourself and you say, well, my PhD is about, my key finding to date is. What would you say to that? Stephanie?
I would say mandatory cancer awareness within the school curriculum, please.
Very good. Excellent. So that you have a key message. And it's often very hard to distill all the massive amount of work you've done, your thesis, all those reviews of literature, that experimental work down to, and distill it down to one sentence. So you've a please, a request, and you can then go forward and say, well, that my request is based upon all of this evidence if you get the chance, but you've made the request. Very good. Anybody else like to take up that challenge?
I might attempt next. Mine probably won't be as eloquent as Stephanie's, but I'll try. I suppose we're treating the tumor, but we cannot forget to treat the person and the host, for want of a better phrase. And supportive care services are so important, and we can digitally enable them as well. And I suppose really supporting that person's quality of life, because that is the most important thing at the end of the day.
Okay, fantastic. Anybody else like to take up that challenge? No, that's okay. I have another follow-up question. And the follow-up question is, I'm sure there are other PhD students and researchers online here, and you've been engaged in your research over the past while. Some of you may be in first year, some of you in fourth year, or various stages. If there is another PhD student listening or somebody else engaging in research, have you any key message that would kind of help that student? Something that worked for you, an enabler, if you like, that helped you with your PhD or with your research more broadly that might help somebody else. Some key nugget that you found really helped you with your work. Erica.
I would recommend that people reach out to other PhD students because for me, especially at the start, I found it quite daunting and a lot to navigate, and it has definitely helped having support. I see Teresa there, and reaching out to colleagues and other people in the same situation has been key for me, and I would recommend people do that.
And that's a really important message. I think Sarah.
Doesn't matter. Sarah, mostly. I have 2 questions. One is for Katie, and one is actually for all of the PhD students. The one for Katie is about the supplement use. Do patients not get asked about supplements, or is there inadequate attention paid by the consultants to supplement use? Maybe I'll ask the follow-up question after you answer that. Sorry.
No, thank you very much. Thank you for the question. So I suppose it's a bit of both. We have a lack of education around supplements, particularly with sort of non-dietetic fields, and that our medics are under such time constraints in these appointments that there is just no opportunity to ask, and it's not filled in. So, we're checking their adherence to their endocrine therapy, but we're maybe not checking their adherence to their calcium or their vitamin D or any other supplements that they're taking. I would say, is the onus on the consultant? Probably not. I think the onus is on the supportive care services that we have around, and we need to build those up. And I suppose from a patient perspective, it's maybe something that they feel that they might get a slap on the wrist for if they're saying they're taking supplements. That was what we got from a lot of the qualitative research, is that, oh, we weren't asked, I didn't know what to ask, or I was a little bit scared of asking for being told no because it's maybe working for me, but they might not approve of it.
Thank you. Question, I guess, to all of the students, and it's kind of a follow-up of Josephine's. What's something that you're missing? What's something that staff could do to better support you? So I suppose particularly for the ones who are almost finished, what's something looking back that you thought, oh God, I would really have appreciated that? And to the people who are fairly new, what are things that you think, oh, I would really like this?
the really good questions. So anybody like to take up that challenge in terms of that question? Is there something you feel maybe it could be strengthened, or maybe it could be introduced? Maybe we've seen it elsewhere. Anything that you think would enhance your journey, but it currently maybe isn't strong enough or could be enhanced?
I might jump in if that's okay.
Yeah, Katie and then Teresa. Yeah.
Suppose I've had a really positive experience, Sarah, from my PhD. I suppose mine was a little bit unusual, that I had maybe 4 or 5 different disciplines all at the same time. And I think being able to reach out and talk to different people at different stages was really, really helpful in terms of my peers, in terms of my mentors. I don't think it's something that needs to be strengthened, but I think your relationship with those around you are really, really important. And something that I would say for PhD students coming through is just ensuring that you're nurturing that relationship that you do have with your mentors and your supervisors, because it's so, so important.
It's really helpful, Katie. And Teresa, you wanted to come in.
Yeah, I think sometimes you can be quite isolated doing a PhD, and there's lots of support out there. There's so much that's available, but sometimes you just don't know where to go or who to ask. And like that, I think having, situations like this where you can connect with people. Equally, I think the UCC Library, the UCC Skills Centre, there's such fantastic support available. So just going into the library, going into the Skills Centre and actually talking to people, they will point you in the right direction, because there is so much out there. But sometimes we're just not aware of it. It just hasn't maybe reached us. So yeah, reach out, ask, talk to people, definitely.
Yeah, that's one of the key messages, I think. Reach out, ask, communicate, in terms of, if something you're missing, something perhaps is there, but even by asking, you're kind of stimulating the discussion about getting it into the system. Anybody else like to take up that question for Sarah? Anybody else feel there's something that they feel could be strengthened or added, or they've experienced elsewhere?
I think for many people, that people are doing their PhDs in combination with a work or working at the same time. And I think being very clear in terms of boundaries with that and with your work support is very, very important. And I guess that's the experience, especially with Eric and Teresa, who are still working pretty much full time and doing a full-time PhD. It's quite difficult. So it's just trying to ensure those boundaries, I think, as well from the start.
And even a lot of PhD students I've encountered, in terms of their carrying maybe the kind of lot of caring responsibilities, other responsibilities. So it's very difficult to carve out the time for the PhD, and maybe negotiating those boundaries with all involved. And it's very helpful to have protected time for the PhD, whatever one's circumstances, be it working, be it full-time, be it part-time, whatever it is, but being clear about where the time is to do the work, so that it doesn't become too difficult when it all comes together when a PRP is coming up or whatever. Sarah, does that answer your question, or is there anything you'd like to ask further?
No, it does. I guess it's something that as supervisors we kind of need to be aware of also assisting students with connecting with others, being proactive and saying what's something you need, because as staff members we might have a broader network of contacts, details.
Very,
Thanks.
very good. Excellent. Thank you, Sarah. And I see Susan. Susan, you've put a nice comment in as well around Ken and all the excellent work he's doing in terms of profiling the research funding steps, etc., and the intraweb and support structures available therein. So, Susan, do you want to come in?
Yeah, and I just put in Ken's details, just if anybody wanted to connect with him, particularly around research funding and what would be available. He's happy to discuss with anyone. In relation to just connection, and I know like all you guys are working in the cancer space, but the college does have a postgraduate student committee, and it has people at all different levels. So if you want to connect there, Elaine Lehan is our vice head, and Jane Hurley is the administrator. So it's good to connect with other postgraduate students, and there are people who are working as well. So it's good to connect in, and you have a sense of community of practice there, just in case you weren't aware of it. But I'll put their contacts in the chat as well.
Yeah, and Susan, that committee organises kind of seminars, learning opportunities, social events on occasion. So, and they're
Yes.
excellent because I've been to a number of those as well, and they're a great way of meeting somebody, just sitting down, because everybody's in the same boat. They may not know anybody, so it's great to sit down with somebody and have the chat and maybe find out about other supports and maybe
Absolutely.
a common interest even that might
Yeah.
do some further research. Or
Yeah.
you just don't know what
And
conversation will
there's a
be
lot of
something new.
opportunities for support and training, from the Dean of Doctoral Studies. So what they're trying to do now at the moment is gather information from postgraduates in terms of what kind of tailored training do we need for the College of Medicine and Health specifically, rather than duplicating what Orla Lynch is already doing. So, it'd be great for people to feed in there. And I think next week they're going to have the postgraduate student awards, so that's a social occasion, and it will have been postgraduates nominated by students and awards given to students, so it's a nice social event as well.
Fantastic. And I think we're really coming to the end, Aisling, I think at this stage. Is there any other final question that somebody wants to share, or maybe a piece of information that, like Susan mentioned, there's a lot of resources out there, and reach out to Ken in the in the College of Medicine and Health in terms of the research offerings, reaching out to the postgraduate committee and Dr. Leonie Hahn. In terms of the offerings through that committee, there's there are a lot of opportunities to engage, link with others, but sometimes you do kind of first move yourself just to reach out. So, any other questions? Any other thoughts? And Graduate Studies, the link is just up in the chat as well. No, I just want to reiterate, because Emily's online here. This is our last session of this particular series for the past academic year. Going forward, there'll be new sessions starting, a new series starting in for the next academic year, 26-27, and that will be a series of events like this. And hopefully we'll have another opportunity to showcase PhD students at the end of next year as well. So we could hopefully have this as an annual event, because it's fantastic to hear from all the different disciplines and all the excellent work that you're doing. And it is a particular skill to be able to distill your research down to the kind of 5-6 minutes as well. It's quite difficult, because you have so much to share. And we really appreciate you taking the time to do that and share it with us. Aisling, is there anything else you'd like to say before we close this?
No, other than thank you to Emily, who did all the organising this year, and we really appreciate everything that you've done. And thank you to you, Josephine, for co-chairing this session. And I look forward to doing this again next year. I think it was valuable.
Yeah, it's very valuable. And thank you for attending on a lunchtime period when you're busy, particularly with exam boards if you're involved in an academic context, or with clinical in terms of your other work. So really, we appreciate the time that you've given us here today. And we'll close this session and say thank you to everybody. Thank you.
Thank you.
Thank you.
Congrats.
Congratulations to you all. Bye-bye now. Thank you.
Thanks.